Today we have the pleasure of hosting Drs. Peter Gliatto, Dennis Chang, and Reena Karani for a talk on medical student mistreatment. Dr. Peter Gliatto is the Senior Associate Dean for Undergraduate Medical Education and Student Affairs at the Icahn School of Medicine at Mount Sinai, and an Associate Professor in the Departments of Medical Education, Medicine, and Geriatrics and Palliative Medicine. He received his medical degree from the University of Rochester and completed his residency and chief residency in internal medicine here at the Mount Sinai Medical Center. He's board certified in internal medicine as well as in hospice and palliative medicine, and cares for patients through the Mount Sinai Visiting Doctors Program. Dr. Dennis Chang is an assistant professor at the Mount Sinai Medical Center in the Division of Hospital Medicine. He received his medical degree from the University of Chicago and completed his internal medicine residency at USC and NYU. He currently is the director of the third-year medicine clerkship and director of education for the Division of Hospital Medicine. Dr. Reena Karani is professor of medical education, medicine, and geriatrics and palliative medicine at the Icahn School of Medicine at Mount Sinai. She serves as senior associate dean for undergraduate medical education and curricular affairs, and in this capacity oversees the education program leading up to the MD degree. She is also director of the Institute for Medical Education at Mount Sinai. She completed her residency and chief residency in internal medicine at Montefiore Medical Center of the Albert Einstein College of Medicine, and her fellowship, chief fellowship, and medical education research fellowship in geriatrics at Mount Sinai. She also received a Master of Health Professions Education from the University of Illinois at Chicago. Please join me in welcoming Drs. Gliatto, Karani, and Chang.
Good morning, everyone, and welcome. Thank you for joining us today for this very important topic. We have no disclosures, and we hope by the end of our time together, we will all be able to recognize the Association of American Medical Colleges' definition of mistreatment and the behaviors that constitute it, to become aware of our school-wide approaches to address student mistreatment, and really, as a group, commit to efforts to eradicate student mistreatment. So I want to present 4 cases to you briefly. I'd like you to reflect on these cases as we go through our presentation today, so I'm going to read them out. A student answers an attending's question incorrectly on rounds. The attending snaps, "Are you kidding me? Even my preschooler knows that." The student reports this interaction to the Dean for Medical Education. The Dean reviews this attending's teaching evaluations and finds them universally positive, except one comment notes that he is rough around the edges. A 4th-year medical student is doing nights during the sub-internship. The attending on service requests that the student get coffee from the coffee cart on the street corner each morning for the team. Reluctantly, the student stands in line for 10 minutes each morning in the brutal cold of the winter. And during this time, the remainder of the team completes their morning huddle on overnight events. A resident asks the student to consent a patient for the preferred procedure. The patient only speaks Spanish. The student raises a concern that she may not be able to answer the patient's questions. The resident states, "Listen, you speak Spanish, so you can definitely consent this patient way better than I can. Just tell her to sign on the dotted line." And finally, a resident tells a student that it's ridiculous that the student has chosen ophthalmology as their chosen field and nicknames the student Schlem. The other members of the team also start referring to the student by that name. So as we go through our presentation today, I'd like you to reflect on these cases and consider whether in your mind, these would constitute mistreatment, and if so, and how. So the discussion of medical student mistreatment in the medical literature started in 1990 with Henry Silver and Anita Glicken, who presented an article in JAMA. And their call to those reading this was that the prevention and management of abuse should be a major concern of those who are involved in the education of medical students. And this call reverberated with the Association of the American Medical Colleges, who convened a group of people together to try and come up with a working definition of the behaviors that would constitute mistreatment. These 12 behaviors and the preceding statement, which says mistreatment, either intentional or unintentional, occurs when behavior shows disrespect for the dignity of others and unreasonably interferes with the learning process, included the following 12 behaviors: being publicly embarrassed, being publicly humiliated, being threatened with physical harm, or being physically harmed, being required to perform personal services, being subjected to offensive sexist remarks, denied opportunities for training or rewards based solely on gender or race or ethnicity or sexual orientation, receiving lower evaluations or grades solely based on gender or race and ethnicity or sexual orientation, subjected to unwanted sexual advances, asked to exchange sexual favors for grades or other awards, subjected to racially or ethnically offensive remarks, and either then subjected to offensive remarks or names related to sexual orientation. And these large categories of behaviors became the working definition from the AAMC that began appearing in the graduation questionnaire. So the time around which this committee came together to define the behaviors also was the start of assessing whether students were mistreated. The Association of American Medical Colleges administers a graduation questionnaire, which is a very long survey to senior students just before they graduate from accredited medical schools in the United States. It's a long survey that assesses their opinions regarding the learning environment, support from faculty, their experiences in the medical school, their knowledge of various different clinical behaviors and clinical topics, and since 1991, questions regarding mistreatment. In 1991, the question began with what we call a gateway question, and that question was, have you been personally mistreated during medical school? And once a student answered yes to that, they were then offered the different behaviors that we just spoke about and asked to rank or note whether they had experienced any of the mistreatment in those categories. Since 2012, that gateway question was removed. And so students basically got the list of behaviors, and for every behavior, were able to answer whether they had experienced that category of mistreatment frequently, occasionally, sometimes, or never. So that is how the data are reported to each medical school. One more comment about how data are reported back to medical schools is that schools receive their data from all students who have completed the survey. And so you get the data for that entire graduating class depending on the completion rate. And you also receive data from medical schools across the country that have also completed the survey. So you would not be able to tell the University of Chicago data from the University of Nebraska data or from Harvard data, but you will really get to know that of all the graduating seniors across the United States in accredited medical schools, how did they respond to each of these questions as compared to your students? So what we know from national data, if we look at the graduation question data, between 2000 and 2011, between 12 and 20% of graduating seniors reported mistreatment. And in 2015, the most common behaviors that were experienced occasionally or frequently by students included being publicly embarrassed, being publicly humiliated, being subjected to offensive sexist remarks. And what's important to note is that we have almost 13,000 respondents to this question. So this is not a small sample size from across the country. And the numbers are sobering. Now you might be saying, well, look, we ask questions. We're pretty Socratic in the way we ask questions, and maybe I don't intend to humiliate or belittle a student, so I don't really understand the difference. That might just be the way I teach. And so that question about what does it really mean to be publicly humiliated or publicly shamed or publicly embarrassed is often one that has been challenging to define. Because there is this border, this gray zone between what we would say are questions used to assess a student's learning and the concept of pimping. But I think Brian Mavis from Michigan State really stated this quite well. And he said that while gray areas will always exist, when a reasonable person can tell that a student does not know the answer to questions, yet the faculty member continues to pepper the student with questions, the goal of why we're doing that, the goal of the questions has likely shifted from assessment and teaching to humiliation and disgrace. And I think that's an important way for us to consider how we ask questions of our learners. So the mistreatment questions about the behaviors are followed then by the sources of mistreatment. When the student experienced them, who were the major perpetrators of that mistreatment? And the data have shown us across the board from the AAMC that the biggest sources are clerkship faculty in the clinical settings, residents and interns, and nurses. There's very, very negligible data showing mistreatment by pre-clerkship or classroom faculty and other members of the healthcare team. These data are not new at all. Kassenbaum's article in 1998 showed that even at that time, clinical faculty and residents were by far and away the sources of student mistreatment, even at that time. When does mistreatment occur? During the life cycle of a student in medical school. And these data, again, are not new or different over the course of time. The same article by Silver and Glicken showed that when you had students in different years of medical school, reflecting back on when they experienced mistreatment, the largest time periods for them to experience these were in their clinical years, largely in the 3rd year and the 4th year on the wards, which correlates with the sources of mistreatment that students experience. What's quite sobering is to think about whether students report these incidents of mistreatment. The AAMC is very committed, as are schools across the country, to encourage students to report when they experience mistreatment. And in 2015, 80% of students nationwide, remember with that sample size of over 13,000, 80% of students did not report these incidents of mistreatment. Students are also asked to check off why they do not report. And they can check all that apply in this category. Many think it did not seem important enough as an incident to report. Many think that they did not think anything would be done about it at the school level. And a bunch of students feel that there is a tremendous fear of reprisal, since many of the faculty who might be mistreating them are also evaluating them. And I think what's important from this slide to remember is that if you combine the 2nd and 3rd category, we have over 60% of students thinking that something will happen to them or that nothing will be done about it. And I think that for us is the area of challenge for us as educators to really improve on. Lest we think that students are the only people being mistreated, those data are not correct. So a systematic review of 57 cross-sectional studies and 2 cohort studies found that about 60% of trainees experienced at least one form of harassment or discrimination. For medical students in this systematic review, 60% experienced this, with verbal harassment being the most prevalent and physical harassment being the least prevalent source of mistreatment. For residents, it was gender discrimination most commonly, followed by racial discrimination as the least common. These data about other trainees was also present here at Sinai. So our graduate medical education office studied 62 rising chief residents in 2013, and over a third had been publicly humiliated, 13% had been subjected to offensive sexist remarks, about 10% had been subjected to racially or ethnically offensive remarks, and 8% asked to perform personal services. The sources of mistreatment for residents too were faculty and other residents and nurses. And only 23% of residents reported the event as well. So these data are very similar to medical student data. If we think about where mistreatment is occurring most commonly in terms of departments, this was a survey externally of medical students at Hebrew University Hadassah, where verbal abuse was the most frequent cause of mistreatment. And the department there that was most commonly cited was general surgery. Now, they also interviewed faculty as to the perception of students' abuse. And faculty significantly underappreciated the rates of both verbal and physical abuse. And that's not uncommon, this discordance between the perceptions of those most vulnerable and those who are cited as being the mistreaters. And these results are not different from the results we see here in the US. This is a study in 1996 that looked at gender discrimination, the perceptions of gender discrimination and sexual harassment in various specialty areas. And you can see the surgical subspecialties at the highest rate, followed by general surgery, obstetrics and gynecology, and internal medicine subspecialties. This is the perception, the same graph of gender discrimination and sexual discrimination from the viewpoint of male and females. And here we see again, the department stays the same, but the perceptions of male and female residents also parallels that perception. So what's the impact of mistreatment? What does this really result in? There are numerous studies and a growing body of literature to support that mistreatment leads to a lot of interpersonal communication issues, dehumanization, an impact on morale, pessimism about the profession, a tremendous amount of cynicism about the profession. alcohol use, psychological harm, and then inevitably poor patient care. It also affects how people view, how students and trainees view our profession, the profession of medicine. A survey of 75 clerkship directors in 1990 found that, of clerkship students, found that 3/4 were more cynical about academic life and the profession. 1/4 would have chosen a different profession had they known the extent of mistreatment in our field, and half would not recommend that their friends or children go into the medical profession. And these data are very, very sobering. What about this impact of mistreatment on burnout? And we know that burnout has been an area of great interest, not only for trainees, but also for faculty. A survey of almost 1,000 clerkship students from 24 US medical schools found that 2/3 had experienced at least one incident of mistreatment by faculty. Three out of four had experienced by residents, and recurrent mistreatment was correlated with high incidence of burnout among these students. What's even more sobering is the impact of mistreatment on specialty choice. In fact, if you look at senior students and the 5 most influential factors determining their choice of specialty, you will see that clerkships in the area are very highly rated, as are examples of physicians in the specialty. And if mistreatment is occurring largely in the clinical experiences that students are having during the time that they're in the 3rd and 4th year in their clerkships, and they're seeing examples of faculty and other trainees who are mistreating them, this impact on their choice of that field as a career is certainly going to be impacted. In fact, at one school, this was a study published a couple of years ago in Academic Medicine, found the vast majority of students at one school, 65% had been told directly or overheard negative comments about their own specialty choice while rotating on a different specialty. 37% were discouraged from continuing in a specialty or career, with this occurring most commonly on surgery, followed by obstetrics and gynecology and internal medicine. What's really important for us to take away from this is, are we willing to lose excellent trainees in our field because of the behavior that we exhibit in the clinical environment? One of the other parts of the study that was so interesting was this idea that when they asked students who had not experienced mistreatment personally, whether they had observed a peer being mistreated and the impact of that, students said that they were far less likely to choose that specialty when a peer experienced mistreatment in that field. And this is finally the sort of end of my talk part, which is talking about the impact of gender discrimination and sexual harassment during residency selection. In this, 1,300 students across 14 schools, during their residency selection, looking back, almost 28% of women and 10% of men experienced gender discrimination and sexual harassment in the residency selection process. And we've put all the graph up here for you to see where internal medicine was as well, from the both male and female perspective. So the impact of mistreatment is great. It is an impact that will have an impact on our students' career choices and their choice of us as a specialty. And so using that as a framework, we're going to move on to what we here at Sinai do to address mistreatment and look at our data.
Thank you, Reena. So I'm going to talk about our policies and processes at the Icahn School of Medicine, and then I'm going to talk about our data over the last several years. We have an official school policy that we developed 5 years ago, and that came about for a number of reasons. One was that we didn't have a very clear policy at the time. Two, even though it was a very important topic in the literature and in discussions in medical education since the early 90s, there was a real resurgence of interest in this topic about 5 years ago at national meetings in the medical literature. And the other thing is we had an accreditation visit that was coming up, and we realized that we needed to really tighten up our policies. And our policy, that always helps, right? So our policy is that we have a zero tolerance for mistreatment. And what that means is that we'll never ever get realistically to 0 reported incidents, but that every incident is taken seriously and there's never an acceptable time for mistreatment of our learners. We collect a lot of data, and I'll talk about what data we do collect and how we collect it. And we disseminated that. So the data is systematically looked at on a quarterly basis, and that is shared with our departments via our clerkship directors. And every incident that comes to us is investigated in some way. It's very important that students have multiple ways to report mistreatment because students are a vulnerable population. They're evaluated, they're the low people on the totem pole. It's important that they feel comfortable coming forward, and for that reason our policy was built around that principle that they need multiple options to do so. And so one way we do this is through evaluations of our clerkships. So we don't have new innovations, we have something called eValue. And at the end of every clerkship or every course, students fill out an evaluation about the content of that course and evaluate their teachers. So they have specific questions that are asked that are modeled off the AAMC definitions that Dr. Karani went over that reported about each clerkship. And so we have to learn about embarrassment and humiliation, et cetera. We use the AAMC definitions. We still use a gateway question. So have you been mistreated on this clerkship? Yes, no. And if yes, then you answer specific questions. We did that so we'd have comparable data over this time period. We encourage our students to reach out directly to their clerkship and course directors, and we've noticed in our data that that's been an increasing source of students reporting mistreatment. We have 6 core faculty advisors in the medical school. Each advisor has a 6 of each class. They meet with the students regularly, and they meet with the students throughout their course in medical school. And that is also a place where you direct students. We have 2 specific ombuds people. That's Dr. Kirk Campbell in the Department of Nephrology and Helen Fernandez from Geriatrics. And those are people outside of med ed that students can go to in a very confidential way and bounce ideas off of. And we encourage students to reach out to them if they have a question about mistreatment. We always encourage students to come to us with any issues, and we have open office hours is one way for students to approach us. And there's also easy ways to schedule appointments with us online. And we have something that's unique called the Student Mistreatment Resource Panel. So this is a group of students elected by, just the way student council is elected. There's 1 rep per year as well as reps in the grad school. And students can report mistreatment to this panel either through an anonymous email or through their rep from their year. And that student will then bring that mistreatment issue to the panel for discussion. This panel doesn't adjudicate and it doesn't investigate, but it's a way for reporting to happen. So it's another option. So you can see there's many options for students to report mistreatment. And again, we feel that's important. This policy is disseminated at the beginning of every clerkship, as well as the beginning of every year of medical school. We've added a couple of things this year to increase our catchment of mistreatment episodes. So one is that when the students evaluate their teachers, they not only do Likert scales of their teaching skills and things like that, they type in free text response. And so we do keyword searches of these comments for things like mistreat, embarrass, things like that. As Dr. Karani went over, we look at our GQ data every year, which is qualitative data. And then we've added 2 questions this year to every teacher as evaluation. Were you treated with respect by this person? And did you observe others being treated with respect? And there's a space for students to enter information if the answer to either one of these questions is no, and this has resulted in us looking into many more episodes. So what's our data? So I'll share the good stuff first. So this is over the last 5 years. The GQ has asked their students, are you aware of your school policy? And so I'm happy to say we went from 50% in 2010 to nearly 100% over the last 3 years. And do you know what to do when you are faced with mistreatment? And again, our data looks good. It went from about 86% to 98, 97% over the last couple of years. Is there a question? Okay. This is our the data based on behavior, and you can see that overall we're higher than the national average in terms of students report being publicly embarrassed, publicly humiliated, subjected to offensive sexist remarks, lower evaluations based on gender, and you can see the other ones there. Also, overall, our numbers sort of jump up and down. varying anywhere from about 35 to about 45% of students who reported that they've been subject to some sort of mistreatment. Again, this is when students are finishing med school, so they're reflecting back over their entire time at medical school. But we do have some data that most of these episodes happen in the third and then some in the fourth year. In terms of who is implicated in mistreating our students, is very similar to the national data. Whether or not you separate out humiliated or embarrassed from the other data, it's mostly our clinical faculty and our residents and interns, as well as nurses and, interestingly, students. Unfortunately, similar to national data, many of our students do not report it, although we're a little bit better than national average. Almost 75% of our students who experienced an episode of mistreatment did not report it to anyone. And similar to national data, the main reasons are they felt like it was not an important enough incident, and they felt like nothing was going to be done about it, or they felt there was a fear of reprisal. But the good news is that the number of students who did report is going up. And most of them are reporting to faculty members, and we think that's mostly clerkship directors that they're going to. About almost a quarter to other medical school administrators, almost a quarter to Dr. Karani and myself, and about 15% to the ombuds people. So that's good news. And in terms of by clerkship, again, we share our data with each department on a quarterly basis. You can see here that for last year, integrated med-geri, the overall rate was 3.29% of students over the course of the year of third year reported some episode of mistreatment on either the medicine floors or in the geriatric clinics. So now I'm going to turn this over to Dr. Chang to have the presentation.
Thanks. So I'm going to kind of finish our talk talking about some of the interventions that have been successful and some of the struggles around the country around how to improve mistreatment. So one of the first large studies was done at UCLA between 1995 and 2011. It was they sort of studied it in 4 different periods, and they sort of did a staged rollout of these interventions. So some of the interventions that they had were they had a gender and power abuse committee. They created an office of the ombudsman, similar to here, that sort of investigated these issues around mistreatment. They had extensive policies that were done, and it was disseminated pretty broadly. They even also had, similar to what we're doing here, grand rounds that were sort of given to different departments and at faculty meetings around mistreatment. And they also created a pretty extensive, comprehensive sort of education program for faculty, residents, and students. And they even had some mandatory sort of workshop-based skills that they gave to students to try to improve mistreatment. And even at a governmental level, the state of California mandated that online sexual harassment training be given to all physicians with licenses every 2 years. Unfortunately, when they looked at the 4 study periods, the rates of mistreatment remained the same across the 4 study periods, even the last study period when all of this multi-pronged approach was in place. So it really shows you how difficult it is to change behavior, change culture, and really improve mistreatment. So how about some success stories? Okay, so this one was done at Brown, where they actually took residents and they had them role play different scenarios around mistreatment. One of the examples they gave was an attending gave a sexist joke, and the residents had to role play how they would respond as students. And what was great about this study is they also looked at they talked to the residents after the role play, and they asked them how did this change their sort of, thinking about mistreatment. And most of them sort of talked about how they were much better at recognizing and maybe even dealing with mistreatment. And the greatest part is they all said that it would help them avoid mistreatment of students and residents in their future careers as attendings. So I'm not going to ask you guys to role play or anybody here to role play any scenarios. However, I think that some of these things that you can do is really reflect on all the things that when you were a student, when you were a resident, some of the things that you may have observed you may have seen, you may have heard about, or maybe even experienced yourself. Some of these comments that sometimes don't seem that bad all in of it itself, but when you think about it around mistreatment, you can kind of reflect on, wow, that's probably not something I would ever say again, or that I would ever say that I heard somebody say. You know, unfortunately, a lot of these things, every single year I hear this one, telling the student that we don't want to hear from them on rounds. Every single year I hear about this from a student. So this is not a problem that has gotten better or is going away. It continues to be there. And one of the first things that we all can do is just kind of reflect on our own experiences and our own behaviors. So I think awareness is probably one of the biggest things and one of the things that we're trying to do with this Grand Rounds. The other thing that some of the studies have shown is that feedback really matters. I think we all know this from all kinds of other literature on education and behavior changing, is feedback really matters. So at the University of Chicago, they actually did a pretty huge sort of reflection of all their own programs around professionalism. And what they found is that faculty often saw the problem of mistreatment as a medical education problem or a student problem. So again, this idea that the students or the residents are just being too sensitive or whatever that may be. And I think sometimes what we have to see is that we showed a lot of the data over the last 20 or 30 years. That data has not changed. So those students that we think are sensitive now, 10, 20 years ago, we were those same students. And we were feeling that same mistreatment. So this is a problem that continues to be there. Another study which was really great was out of Southern Illinois University, where they actually surveyed all their students, and they made them kind of identify those faculty who were most professional and those who were least professional. And what they found, and the least professional faculty were given feedback from the dean. And what they found is those least professional faculty, once they got feedback, their rates of mistreatment actually went down. Their rates of being sort of said by the students that they were unprofessional, those went down from 126 when this started to 6. Okay, so feedback does matter and it can improve behavior. Another sort of strategy that that some universities have used is something called longitudinal clinical experiences. These are popping up all over the country, including here. And this was done at Harvard, where they basically have, instead of the students working with different rotations, different attendings every couple of weeks, they have the same preceptor, they have the same sort of home base. And what they found is that mistreatment was decreased because there was more bonds between the faculty and the students. So what are we doing here? So I think Dr. Gliatto really laid out some of the policies that we've created here. So one of the things is just raising awareness. So this is what we're doing here, is just raising that awareness that it's erroneous to believe that the students are simply just becoming too sensitive. And in order to change behavior, we have to raise awareness. We have frequent reminders about the zero tolerance policy. I think every student who's here right now knows that every single clerkship they're at, they're told about the zero tolerance policy and how to report, and that's why all the students now seem to know the policy and know how to report it. We have a very open door policy to meet with students. I tell the students at every clerkship in the beginning that please come to me with any problems as early and often as possible. And what's great is that the leadership of the medical school is always available for these issues. Dr. Mello, who's sitting here, Dr. Karani, and Dr. Gliatto are always available to kind of deal with these issues around mistreatment. So these are the cases we started off with that Dr. Karani spoke about. And I think what's important is just to think about these cases and think about the things you've observed, that you've seen, that you've heard about, and all the things that maybe you were experienced when you were a student or when you were a resident. And I think it's important to raise this awareness in your own mind and for everybody around you, because as Dr. Eckenfeld said, today's abused student is tomorrow's source of social control as a resident or attending physician. The consequences of students' abuse seems clear, and if we do not intervene, the problem will continue. So the cycle will continue unless we all reflect on our own behaviors and the behaviors of those around us so that we all can break that cycle of mistreatment. And thank you for your time. We'll leave it open for questions.
We have some time for some questions, and just want everyone to know that the department is 100% committed to the school's zero tolerance policy. And that comes down from Barbara Murphy. And this data is all discussed at the leadership of the school. I present it to, after Dennis gets it to me, I present that back to Dr. Murphy, and then she has discussions with the leadership of the dean. So this is an incredibly important issue for the department, and we're very supportive of this initiative.
As someone who could potentially be a teacher on the wards, I wonder two things. The first is, at the beginning of someone's teaching experience as a teacher, are they presented with the information on which they'll be evaluated? And then what are the specific feedback mechanisms to that teacher at Sinai?
So I think that, in your answer to your question about what kind of data you're sort of given before you start the teaching rounds, I think that's something we're continuing to work on, but we definitely, I get all the data from eValue from the students, and I also get data from Dr. Gliatto and Dr. Karani around mistreatment. So anything that's come up in the last 3 months, I've either heard about from the student already, or I've heard about from them afterwards, and we do feed that back to the attending to that.
I don't need data, I need criteria. No, as
Okay.
a teacher, I would like to know what is it that I'm being evaluated for, because
Yeah.
that can help me. That would increase my awareness of what's important from a student's perspective.
Okay, I think that's a good point, and I think that's something we can do a better job. I do meet with a lot of the faculty who are teaching the students about this, but we can do a better job of sort of laying out the criteria of what they're being evaluated on.
First of all, congratulations on taking on such a difficult and important subject. I think a lot of what you're talking about is anger within the attending and teaching staff. And I wondered, first, do you have a psychiatrist working with you to look at this anger issue? And at a less important level, once I have the microphone, is what is the role of the changing income climate for the teachers in terms of private practice, voluntaries, and so forth, and the huge percentage of those not born in the American culture having to learn the American culture to be able to teach? And the third part of that question is, how does the internet diminish, if at all, the role of the teacher and produce some of that anger?
So,
All right, I'll try. I don't know if I'll be able to address all of those. I think your first question was about anger on the behalf of the teachers, right?
The psychiatrists in your team.
And is there, so specifically, there's anger of teachers, and it sounds like the anger you're describing is because there's so many, they're getting pressure from so many places,
Well, whatever the reason, it's angry behavior toward people who are innocent.
So when we learn of a mistreatment issue, and it's somebody's name, sometimes it's an anonymous complaint and the person's not named, we can't do much with that, except note what clerkship it's from, perhaps what site it's from, and if there's a critical mass, at some point address that. If somebody is named, if the perpetrator, alleged perpetrator is named, we will look into that, and based on the nature of the complaint, sometimes it'll be the clerkship director looks into it, sometimes it's Dr. Karani and myself who will look into it. When we meet with that person, we try to hear that person out and give them the feedback. We do not have a psychiatrist sort of on hand to help with those kind of situations, and most of our experiences are that when people learn about this, that they feel sort of embarrassed and a little bit contrite, and it's not always the case, but when there are people who resist the feedback, that's a pretty strong signal that they may not be appropriate for teaching.
I was thinking psychiatrist as a therapist as much as part of the research team to look into this anger aspect.
No, I mean, again, I think what's interesting is that the debate, at least in the medical education conferences, has shifted to how do we help students deal with this, to what is driving this, and you're getting at some of those things right there. I don't know if it's been systematically studied in that way.
Could I just add something from the department perspective? So Dr. Ali, our Vice Chair of Faculty Affairs, has thought a little bit about this and is developing a wellness program for faculty specifically, in an attempt to get this from another angle from the department perspective.
You had other parts of your question I don't know if we the answers to.
Well, I think the internet may be diminishing the role of the attending as a source of information. I don't know whether that's been studied.
I'm not aware of that being cited
Right.
either. Yeah.
And my sense, Dr. Lebo, is that this is less about, teaching. It's not about sort of what I'm learning like from a person, as much as it is much more about the behavior towards students, even if it's not content delivery, right? So it's not like the separation of sort of how someone teaches. Yes, you might sort of move into the public humiliation as a method of teaching, but most of the other behaviors are very, very sort of separated from the teaching aspect. And I do not believe that the data that we've seen nationally reflect on whether someone's come to the United States and whether there's a cultural impact. I think this is actually a lot of it is sort of either with the way we were trained or the way we see ourselves in the hierarchy of the system, and therefore how we treat the vulnerable.
Well, I wasn't blaming people from other nations. I'm just saying it's a hard gap to jump to understand the students from another culture.
Your turn.
So it sounds like over the years we've done a really great job of increasing student awareness of how to report mistreatment. Yet the numbers are still very high of students who don't report mistreatment. So it doesn't seem like it's an information issue. It's not that students are aware, but a big chunk of students said that they either feared some sort of reprisal or they didn't think anything would be done about it. So I wanted to focus on that issue a little bit more. What sort of information is disseminated to students about the process of acting on mistreatment, how faculty or how staff are held accountable, and for that I mean what sort of follow-up is there on the alleged behavior, how are they monitored, is there some sort of surveillance? Because I think this is an issue of student confidence in this process, not so much not knowing what to do.
Right, and clearly that's a national issue, right? That is not a Sinai issue in particular. And I think some of it is that one of the things we've done in our orientation descriptions to students when we discuss the methods of reporting is that this past year we were able to share with students some de-identified data about what happened from the complaints we received. Some of them are investigated. We have some people on probation from teaching. We have some people who are no longer teaching. We have faculty and the chairs involved in helping rehabilitate some of our perpetrators, and we even had a particular member of the interprofessional team who, where the student complaint was one of many complaints that led to that person no longer being at the institution. So one of the things we're trying to do is be more transparent as much as we can, yet protecting the confidentiality and respecting those issues of presenting to students what has happened with some of the complaints we've gotten. The other thing we have done is when we work with students directly who come to talk to us about issues and their issue is resolved, we've asked them to be able to champion with their peers the fact that they've appreciated or approached the system and they were heard. Because we can't disclose that a student came to us and this is what was done, but students certainly in their peer groups have been encouraged, if they felt the process was transparent and helpful, to try and outreach to their peers to know that they could come forward and let us know because something was or will be done.
And in the department, if something comes to us that's by name and it's investigated by both Yusuf, Dr. Ali, and myself, and last year there was a faculty member removed from teaching medical students as a result of an investigation.
Yeah. What are you doing proactively? This is sort of like a follow-up to Dr. Solomon's question. It seems to me that, looking back at my attending experience, basically we went to the wards and we started to attend. We had no real instruction or expectation. It was basically how we were taught as students. That was the model that we used to teach when we were the attendings. It seems to me that a more proactive approach towards when attending starts making their rounds would be very helpful as to what's expected and what sort of behavior is really, out of bounds.
So, I mean, obviously this is not at a scale of the entire department, but Department of Medicine has a lot of faculty development that they're developing around trying to help people do bedside teaching. The Division of Hospital Medicine, who now does a lot of the teaching on the wards, I run a faculty development for all first and second year attendings about how to teach and what are the good strategies in order to teach and sort of include everybody. So we are trying to really try to improve the faculty development around bedside teaching and try to teach people the skills to do a good job. Because I agree, when I started, I just did whatever whatever did for me when I was a resident that seemed to work for me. And so, yeah, that was the model. And modeling is still a great strategy, but I think we're trying to formalize that on a much broader scale for the hospice as well as Department of
It might
Medicine.
just take an hour orientation.
Yeah.
I don't know how often the attendings change on the service, but
Yeah.
an hour orientation as to what's not to be done and what's not to be done.
Yeah. So yeah, we are doing a lot more faculty development in the last couple of years that we did not do 5, 6, 7, 8 years ago.
I think that had
Yeah.
At another organization where I worked, we had similar data, and we didn't have the infrastructure for medical education that we have here, so we brought in a consultant to help us tackle some of this. And what I found very interesting is the consultant actually had us all in small groups, all the faculty, anybody that touched students or residents. And they worked with us, and they put up cases, or they put up phrases or things, and we were to define them whether these were red, yellow, or green. If they were green, they were safe. If they were red, they were terrible. And if they were yellow, it was something in between. And I think we all recognized what was red, and I think we all mostly recognized what was green. But we had a lot of trouble discriminating what was yellow. Things like off-color jokes with students, or other things that we might not realize really upset the students. And that small group experience, which was about an hour for everybody, was extremely helpful because we saw data improve after that. And the plan was to continue to do something like that on a yearly basis. So I'm just wondering if that's what you're doing, Dennis, with our faculty?
Yeah, I mean, that's a great idea. Actually, I think we have addressed more about like how to be a good teacher on the wards, not necessarily directly about mistreatment, although I think that's probably a really good thing to do.
Because I don't think the faculty know exactly some of these things. I mean, those of us that were trained years and years ago where this was an everyday event, I think we know what we felt in those days, but we also probably in that yellow zone, we could use some help with education.
I think that's a great point, and I think that would be a great sort of exercise to try to do with the faculty.
Please.
I'm a preclinical student, so I don't have as much knowledge about mistreatment in the clinical years, but I do have experience myself reporting with 3 other classmates sexual harassment by another classmate, and I've also seen other students that have reported racial discrimination in the school and have essentially been told that professors are doing better than they used to. And so my question is, when we see this mistreatment being reported and see it go into a vortex and see no results happen, is there a point at which the school decides that this is something that maybe outside help or consultants, as you mentioned, should be called in for to determine how to design a process to better address these issues?
My take on that is that I don't think we have ever had a situation where one approach is going to fit every single complaint we get. I'm sure there are situations where students have reported issues of mistreatment that are not even in the domains you mentioned, where they felt like that particular complaint did not meet to their satisfaction in terms of outcome. I cannot comment about the sexual harassment case because that's an ongoing case under investigation in the school, so I cannot, unfortunately, comment on that. In terms of the racial issue of faculty, I will tell you that the school, and many people here, if you haven't heard, the school is engaged in a very concerted effort to try and work on issues of racial discrimination, racial harassment, the way teachers are teaching. For me, the way I see it is it's an ongoing journey and process that is not one that's going to be able to be fixed today or tomorrow, but one that we have expressed in every possible way a deep commitment to working on and a journey toward improving every single day.
I'm curious about those many mechanisms of reporting and who you're reporting to. If there's any sort of sensitivity or training or certification required of those persons to be knowledgeable in things like sexual assault or gender or race. When you're reporting to somebody, I would hope that there would be some sort of requirement that that person be a knowledgeable advocate for you instead of just sort of another person who was promoted up med ed.
All right, no, I think that's a great area of importance, I think. I would argue that getting trained on even what the resources are for each of those groups of people so that they understand that even if they might not be able to advocate for someone, if they know that a complaint has been received in a particular domain, what are the channels? Almost like you might have policies in an institution. If you know what those policies are, then you know how to activate that system. And I think that as a member of our Student Mistreatment Resource Panel, I think that's a great area that we can certainly work on together, and I hope we can.
And as you know, this is a rapidly evolving thing, not just here, but at universities throughout the country. And so Title IX, I don't know if you saw an article a couple weeks ago about how almost even Harvard and other big schools are struggling with Title IX. That's something that we are starting to realize there's an intersection here between that and mistreatment. And so several of our staff, and actually we are getting trained in Title IX matters over the next year, at official training venues.
Next question with Barbara.
I don't know if I missed this at the beginning, but I think a huge issue is fear of retaliation, and I don't know if that was discussed, but your presentation of what happens to people is helpful, but I think so much doesn't get reported because of fear of retaliation.
Right, maybe one of the things we can talk about, Dennis, is how when students have come join the clerkship, there's actually a lot now, our clerkship directors have a lot of training on sort of how
Yeah, so, I mean, this happens once, twice, more than that every year where a student will come to me with an issue. And it's something that I really take care of at a very personal level each time, because each student has a very different experience and a different way that they want to sort of address the issue. So I will give them really their own sort of what they would like to do, and I tell them what can be done now, and what can be done afterwards. And oftentimes the students will say, you know what, can we do this after the grades are in, after evaluations are in, and that's totally fine, and then we sort of address it after that, so that there really is no reprisal that attending or that resident can do, because the grade is already done. And so I think that is a real fear of the students, and something that I think is why they're so vulnerable, is that they know that this person can control their grade. And so I really try to work with the student as far as what their preference. Some students are like, I don't care, I want this taken care of, and we take care of it at that time.
But doesn't it go beyond the grade for right now for that clerkship? It might be, for my letter of recommendation, or I happen to work at this hospital in this department.
Yeah.
There's all these intangibles. It's not just these 2 months on clerkship.
Yeah, and I address all those things as well, and it's really, because we have so much backing from the leadership, then if that's really what ends up happening, then that person, that attending or that faculty member is definitely addressed appropriately if those things do happen. Because I do sort of keep track of those students and ask them how things are going and things like that. It's a very difficult issue. It's a very difficult issue.
I just want to say that I'm from the pharmacology side, and I so far I've been rounding with a lot of attendings and a lot of residents and the team. I found that many attendings are wonderful in the way that they're approaching in their care for the patient and teaching, and they dedicate a lot of time on teaching. And I see wonderful things from the attendings here. That being said, a lot of us are clinicians, and go into academic, that may require a little training, and a little catering for the teaching to the student at the beginning would be helpful in the orientation.
Thank you for your comments, a very good comment to end with. And I wanted to thank our presenters for really bringing this topic to the forefront of the department.